Hi, everybody. Welcome to the today's webinar. How are you, Mehdi? You must unmute yourself.
Zileli, how are you?
Hi, welcome. How are you?
Fine, thank you very much. Thank you.
Good to see you. I
Thank
wish
you.
you are in fresh after a great meeting.
Yes. Yes, thank you. Thank you very much. And tomorrow
Mustafa,
I will be in Saudi Arabia in Riyadh for another meeting.
Mustafa, welcome. How are you? We can't hear you. There is something wrong with your connection, or microphone is not working, probably. I don't know what is it. Your microphone may not be working, Mustafa. No? Ömer, welcome.
Oh, thank you.
How are you?
Thank you, Dr. Zileli. Thank you very much. Everything is fine. Are you okay too?
Yeah, we are all fine.
Okay.
I think Francesco did not connect yet, but we are waiting. Okay, this is actually it's 5 p.m. in Turkey. This is our regular webinars on update of spine surgery. We know very well that we have diagnostic problems, and we don't have a good correlation with the MR images or films and the source of the pain. This webinar contains that subject, and we will try to discuss it in different point of views. Mehdi Darmul will be the moderator. Yes, Mehdi,
I
you can
can
continue.
moderate. Thank you
Yeah.
very much, Prof. Zileli. Donc, today, good afternoon, everybody. Today, we will do this sample update of spine surgery with the topic diagnostic and the problem of back and leg pain. And we have for this webinar four eminent speaker, Professor Mehmet Zileli, well known, donc, chairman of WFNS Education and Training Committee. Dr. Francesco Costa, my dear friend Francesco Costa, chief of spine unit in Italy, in Milan. Dr. We have also Dr. Mustafa Kurklu from Turkey, orthopedic surgeon, eminent orthopedic surgeon in Istanbul, and the fourth speaker, Dr. Mustafa Agoglu, chiropractor in and president of Turkish Chiropractic Association. Thank you for accepting our invitation and participating in this webinar. And now I think we start with Professor Zilali.
Yes, I will share my screen, and this is, yeah. Do you see my screen now?
No, no.
Not yet? Oh, sorry. Okay, sorry. That I must. What about now?
Yes, yes.
Okay. I will present a very simple case. This is a 62 years old female. She has had a low back pain for 30 years and right leg pain for 6 months. This is her films, the MR images. As you can see, there is an L5S1 isthmic type of spondylolisthesis and some narrowing in the foramen, and the disc height has decreased
It's
also.
not working, Professor Zilali. The slide not running.
You don't see my slides?
No, no.
Sorry, I don't know the reason. What about now?
Yes. Yes.
Do you see
Okay.
my
Yes,
slides?
the first one, yes.
Yeah,
Okay.
okay.
Now you see.
These are the films of that 62 years old female with low back pain for many years and right leg pain for 6 months. We can just discuss what to do for this lady. I can ask participants or other speakers how to behave in a case like this. Ömer, can you make a comment on that?
Yes, she has a low back pain for 30 years in a long period, and she has a radiculopathy, leg pain for only 6 months. It means that there is another clinical situation around here. In MRI section and sagittal plan, we can see L5S1 degenerative type spondylolisthesis. And I don't think it is a acute lesion. It's very chronic lesion because there is a dysplastic changes at the top of S1 vertebra. That's why I wonder the other sections of the MRI scan, and physical examination is very important. What is the straight leg raising test? What is the result of lower extremity neurologic examination results? And I wonder to make hip flexion extension tests and other hip examination tests. Do you know anything about the examination results?
Yeah. Actually, there is no neurologic deficit. Straight leg raising test is negative.
Negative. What about the hip and sacroiliac joint examination results?
Yeah, sacroiliac joint examination was painful.
Painful. Okay.
Hip flexion and extension was all right.
Okay. In this type of patients, we have to visualize the sacroiliac joint also. It's direct X-ray, CT scan, or MRI.
Okay.
I'm
I
not
can
going to
ask.
talk about the treatment now because we didn't talk yet. After that, we can
Right.
talk about our opinions.
Yeah, right. Thank you. Are there any other participants to comment on the films and what type of a treatment can be applied for this lady? No. Actually, I will shortly present the case till the end. And actually, the sacroiliac joint test was positive. So because of that, we did a injection, a test injection first to the sacroiliac joint. And she got good benefit from test injection. Because of that, we applied a radio frequency lesion of the sacroiliac joint. And her pain completely relieved by RF lesion of the sacroiliac joint. So although many people can think that because of a significant listhesis, the patient should be operated, and probably a short segment fixation must be applied. But the source of the pain was not that ischemic listhesis or that degenerative listhesis, ischemic listhesis, what you say, it doesn't matter. And we did just one injection, and we could manage that patient without any surgery. This is the message of my case. A wrong diagnosis can happen if you just look at the films and do not examine the patient properly. We can have too many mistakes. Thank you for listening to me, and I think we can switch to other speakers.
Thank you,
I will
Professor Zelali.
stop sharing. Yeah.
Is there any question or other question for Professor Zelali from the participant? Now we can move to the second speaker, Dr. Francisco Costa.
Hi,
You are here?
everybody.
Hello.
Sorry for the delay, but I just finished in the operator room, so got the time to connect the video. One second that I have the problem with the PowerPoint, so I am preparing the PDF in order to prepare the lecture because there is a mismatch between the keynote and the PowerPoint. So in 1 second, I save the presentation and I can share the monitor. 1 millisecond that I'm working with two computers. Okay.
For this time, if we have some question from the participant of some comment in the wrong diagnosis. It's a pertinent subject. Low back pain and leg pain and the wrong diagnosis is a pertinent subject and is frequent, very frequent.
Francisco, you can share the screen.
Yeah, I'm preparing. I'm sharing the video, so
yeah, good.
I think
Okay, good.
you see my video?
Yes.
Yes.
Okay, perfect. Sorry for the technical problem. So we know that back pain can originate also not only from the lumbar spine, but also the sacroiliac joint can be a source of pain. So it's quite important to know, sorry, because it's a PDF, is quite important to know what is the anatomy of these pseudo joints and to consider in the differential diagnosis. From the introduction is a complex joint connecting the sacrum to the hips to the iliac joint, and there is a complex system of muscles and ligaments that work together in order to provide stability and to connect the lumbar spine with the hip joint and have a participation in the sagittal balance. So in this presentation, we will see some key points from the anatomy, the clinical manifestation, and what are the program in the diagnostic challenges in order to try to understand when a sacroiliac joint pain must be considered and what is the treatment modalities. Sorry, okay. From an anatomical point of view, is a bony structure located in the pelvis and is the connection between the sacrum and the iliac bone, and with a pseudo articulation with synovial joints. There is these joints have a minimal movement, usually is comprised between 2 and 4 millimeters in all the plane, and there is some gender differences between the woman, especially after pregnancy, because the ligaments become a little bit more less strong and can change due to the changes according to the pregnancy. So this is important, and there is also some hormonal effect. It's essential the role of the ligaments that have a key point in order to prevent the separation of the sacroiliac joints and the control of the pelvic movement, and the muscular and fascial support that guarantee the stabilization of this articulation. From an anatomical point of view, the shape of the sacrum and the bone provide a stability. First of all, there is a firm closure that it's like if you are considering the ancient Roman arch is the key point, the keystone that allow to share the stress and the forces and that provide a stabilization with the joint. Then there is a post closure that's work together with the hip and the bipedalism adaptation according to the standing position and the control of the upper trunk. So it's a complex part of connection between the leg and the column. And in this way, you can understand how it's a key point. Obviously, during the lifetime of a people, there is some changes during the correlated with the age, especially in early adult and puberty. There is some changes, and then with the 60 and to 80 decades, there is a restriction of motion due to the degenerative changes that can affect all the articular plane and also this one. Obviously, the degeneration can reduce the thickening of the cartilage, the sacral and the iliac cartilage, and this provide a less adaptation of this joint and have can reflex to the spine, to the lumbar spine, and to the hip. This alteration can have a distress and abnormal motion and malalignment according to a stressful of the synovial part of the joints that is rich innervated, so there is a font of the pain. An hypermobility or a hypomobility both can be correlated with the distress, dysfunction, and pain, and so on. Also the mechanical injury. So in case of trauma and of fracture, there is an activation of the nociceptor and that are found in the capsule, in the ligaments, and also in the muscle that can provide the source of our pain. Again, we can see some picture where this is indicated in the yellow line, the articular joints, where the alteration of the anatomy can provide some dysfunction. And some predisposing factors are from a biomechanical point of view. So a discrepancy of leg length, scoliosis, gait abnormalities, and pathologies can create distress of these joints. We have mentioned several times the role of the pregnancy, because the stress, the biomechanical stress, provide a further work in this area, and there is also an adaptation of the sagittal alignment of the pregnant woman due to the pregnancy. So, and as well, spine surgery can affect this articulation. It's well known that lumbar fixation can stress also this joint in the similar way of at descent level pathologies. We can have a distress from this point of view. In literature, there is no differences between lumbar fixation and lumbar sacral fixation. Also, if is stress when the sacral is involved in the fixation, there is a higher degree of this problem, but there is no strict correlation and there is no statistical analysis, but there are no very precise study regarding this point. Obviously, the trauma, motor vehicle collision force, and repetitive stress, for instance, like the running for a long distance. So for the marathonite, there is a chronic stress that can provide pain in this region. What is the prevalence? The problem of the lumbar pain due to the sacroiliac joint is quite important, because we can find that is affected 14% of the cases of back pain is due to the sacral joint fracture joint. So it's quite relevant. And the prevalence is around 15 to 40%, so is quite important. So it's more common respect usually as the clinicians consider. So we have to think about this. The pain usually can be referred also in anterior part, so sometimes goes in differential diagnosis with appendicitis, ovarian issue, and pelvic inflammatory disease due to the irradiation of the pain. So it's quite to think, it's important to think about also this aspect. I explained before that the previous spinal fixation may affect these clinical symptoms and is considered between the 40 and 20 and 75% in a 5 years of follow-up. So it's quite important. As I said, there is no strict correlation between only lumbar or lumbar sacral fixation. Also, if it's quite intuitive that when the sacrum is involved, can be stressed a little bit more in a higher percentage the sacroiliac junction. What are the symptoms, the specific symptoms? So usually is a pain, a back pain, but there is a correlation in a leg. Usually is unilateral below L5, like radicular irradiation. Often is distal or middle to the posterior superior of the iliac spine. Sometimes can be confused with a radicular pain. Also, if it's less precise in the description of from the patients. Sorry, aggravating factors and indicators that must be considered is that the pain is worsened with activities like standing, the changing position between sitting and standing, running, as I explained before, climbing, due to the axial compression of these joints. So is quite common in athletes, in a very important athlete due to the micro trauma, and reflex are considered insidious pains with weight loss and nut sweats, morning stiffness and pain relief with exercise, and symptoms above L5 suggest non-sacroiliac joint origin. So this aspect must be considered in order to think also to other things. Regarding the clinical examination, it's not easy to define this syndrome, but is during the physical examining, the direct palpation often have evocated pain. Neurological muscle strains usually are normal, so neurological examination is not meant to define these pathologies. And it's very important, if you think about this, to consider the leg length and the balance of the basinum. Sorry. Some provocation test, the Faber test is the most important, the most common used. So there is a flexion, abduction, and external rotation of the leg with a contralateral pelvic stabilization. But to make a more precise diagnosis, we need at least 3 positive tests in order to have 77 to 87% of sensitivity. So the other tests are the Ganless test, the distraction test, the thick thrust, and the compression test. So here you can see and find it. So we need at least 3 tests in order to consider this syndrome. Regarding the imaging, obviously MRI and the CT scan are useful to see this junction and to see if there is some edema, especially with the MRI around the bone of the sacrum and the iliac bone, to define if there is no other lumbar pathologies in order to make differential diagnosis. The bone spectral CT can define the metabolic activity and define the pain source, but is not specific for this syndrome. The radiography usually can show the degeneration of the joints, and we can define also the alignment of the pelvis. And if it's a full X-ray, we can also check the sagittal and coronal plane, and to define if there is some dysmetry of the legs. Obviously, one of the most diagnostic tests is the image-guided block with some anesthetic and steroids, and usually a decrease of more than 75% of the pain confirm the diagnosis. So is a procedure, and is an invasive procedure that can help in the diagnosis. Obviously, there is some limitation in this test because there is sometimes an inconsistent response due to the anesthetic diffusion, and we must be sure regarding the position. So it's essential to perform with image guided. Usually, there is some authors that use echography. Better is radiography. There is some other that perform with a CT scan. So we can both use all these things. The other differential diagnosis are here present, maybe tumor, maybe pudendal nerve irritation, lumbar facet syndrome, lumbar disc herniation. So we have different pathologies, but we have to think about the localization of the pain that usually is around L5. So if the radicular pain is considered for the crural nerve, we can not to think about this syndrome. Sorry. Regarding the treatment, usually must be considered the conservative treatment. Usually is initially is a physical therapy. Non-SAID, non-steroid pharma drugs can help for the pain relief. Assistant devices and sacroiliac belts may help in order to reduce the stress, the biomechanical stress, and some lifestyle adjustment obviously helps, like the weight maintenance, exercise, a correct posture, and a correction of the core. So strength of the abdominal muscle can help in order to have the compensation between from the muscular part. Education on self-lifting technique and maintenance of the proper posture it's essential for all the back pain, not only from the sacroiliac joints. Advanced non-surgical intervention consider injection again and nerve blocks, so we can repeat also for a therapeutic point of view. In order to have a longer effect, there is also the role of radiofrequency ablation that can offer intermediate relief between 4 to 12 months, in some cases more longer. Again, the efficacy of the injection usually are mainly for the diagnostic test, while have a limited long-term evidence due to the widespread of the drugs. From a surgical point of view, when there is a failure of the conservative treatment and there is a good diagnostic test, infiltrative test, an open sacroiliac joint fixation arthrodesis can be performed. You can see here two different types of arthrodesis tools that have, but however have a complication rate between 6 to 25%. So the selection of the patient is very important. Now there are also minimal invasive sacroiliac joint fixation. So the preferred method using lateral, transgluteal, or posterior approaches can be selected according to the knowledge of the surgeon. Obviously, the benefit is to raise the lower pain scores and reduce the disability and reduce the use of opioid drugs. So this is the main. The triangular titanium implants have improved the quality of the life because it's correlated with a reduced risk according to the shape of these devices. Other surgical techniques, there is a percutaneous screw fixation. Here we can see some techniques proposed from the our site. So there is also the sacral halar iliac strip technique. So every technique where there is a screw that blocks these joints help in the blocking and providing a fusion to reduce the movement and then the source of the pain. Regarding an algorithm in order to help here in this paper proposed by Pawlowski, they propose an algorithm for diagnosis and treatment and allow to help in this differential diagnosis to have an help in order of the timing of the conservative treatment, and then you can proceed according to this algorithm in order to have an improved clinical decision maker. So there is also other, but this seems the most easy and well conducted. The key recommendation for daily activities, we have to consider that for diagnosis of sacroiliac joint dysfunction is essential to use at least 3 out of the 5 positive provocation tests and have an evidence level of B. Confirmation of sacroiliac joint pain can be achieved through an image guide anesthetic block, and we have seen that have an efficacy of 25%, so have an evidence level B. Non-steroidal anti-inflammatory drugs may be beneficial as a part of a multimodal treatment approach, because we have seen that only drugs cannot solve the problem, but may be used just to manage the pain according with the conservative and the physiotherapy in order to reduce the biomechanical stress. And again, the physical therapy exercise program and sacroiliac joint manipulation is a part of the conservative treatment, and the evidence is pretty good with a level B. So, in conclusion, we have to think about the sacroiliac joint when there is a low back pain, especially if it's unilateral in the lower part of the back pain, and if there is some pain in the leg in irritative area around L5. the risk factor is previous lumbar fixation is a key factor. So we have to think about patient after this surgery having still back pain. And the pelvic tilt and L5 incidence need further research to define it is a potential post-fixation risk. So right now we know that fixation is a risk factor, but it's quite impossible to define with the data of the literature right now available what is the relevance of this technique. Physical exam and immediate guided injection represent the gold standard for the diagnostic tools, and the treatment option must be at the beginning conservative with physical therapy, radiofrequency, nerve blocks, and injection, and surgery, so fixation that may be performed in minimally invasive way or in, with an open surgery may be reserved only for failure of conservative treatment and with the patient with a very high degree of pain. Thank you very much for the attention. And if there
Thank
is
you very
any
much, Dr. Francesco, for your excellent and complete presentation. Now we ask the participant for a question. Is there any question for Dr. Francesco Costa? I think Dr. Mustafa has a question.
Okay, how much time we have to consider for conservative treatment? There is no universal status regarding the length of the conservative treatment. At least must be 6 to 8 weeks to consider surgery. So probably I think 3 months is more convenient due to the risk also of the surgery, but I think from 2 to 3 months is necessary in order because you have to change a little bit the biomechanical stress, so we need time to have a good muscular correction and to educate the patient of the lifestyle changing. So I think at least it's 3 months, at least.
Mustafa, you can ask the other question orally.
Yes, Professor Zileli. Yes.
Mustafa has another question. Probably he
Yes.
can ask.
Mustafa has another question, yes.
Okay, I'm reading. So what you refer the okay, regarding the leg discrepancy, there is no minimum differences that are correlated with this syndrome. So probably must be relevant in the creating changes in the pelvic tilt. So probably must be more than 1 centimeter, but there is no specific data regarding this. In literature, in the paper, I refer that is a key point, but there is no any correlation between the length discrepancy respect the frequency of the syndrome. So probably must be considered more than 1 centimeter, but is a personal consideration, is not a definitive data. I'm reading if there is any other question.
Another question?
One comment from Dr. Ken Yonemura is saying that sacroiliac joint pain is deep pelvic pain and there is no correlation with superficial palpation over the medial iliac crest. What do you think about this?
Yeah, it depends also from the type of the patient, because if a very thin patient, you can really evocate, so this 1 hour are more effective. If the patient have an high BMI, it may be very difficult because the strength that you need is more relevant. So in this case, you can consider directly the infiltration to block under the match guide in order to be sure regarding this. But obviously our tests, not all the patients are similar. This is why there is 5 different tests, and also with the changes of the leg and making a different force, you can stress a little bit this joint. So at least in some maneuver you can have some evocated pain. And if you are not sure, you can consider the diagnostic test with injection. But it's really according to the patient type with the BMI, so you have to consider also this aspect. Okay, I see there is another question for instituting event. Again, it depends from the event. Usually can be advocated for more, not a single event, except for the trauma, very important trauma, where the trauma can affect directly the joint. Obviously, if there is a fracture of the sacrum, can be considered. But for the non-important trauma is the repetition of the traumatic event, like the running. For the long running athlete, can be a fatigue stress of the joints and can be affect the symptoms. So it's difficult to have a single movement causing the pain according if there is no direct trauma. I don't know if there is any other. I don't know if I missed some question.
I think we can skip the
Yes.
other speakers.
Okay.
Thank you. It was
We
great
can move
talk.
to now we can move to the third speaker. If there is
Thank you
no
very
comment,
much.
no question. We call Dr. Mustafa.
No. Ömer will talk. Ömer Akçal.
Okay, Omer. Okay.
Hi, hello everybody, dear friends. Let me share. Yes. Do you speak? Excuse me. Do you see my?
Yes.
Yes.
Very
Okay.
nice.
Okay. This is a very good opportunity to share our experiences among us. That's why I would like to thanks to organizing committee for inviting me. This topic, yes, this topic is clinically is very important because still we can see some problems regarding the source of the differential diagnosis of leg pain. Osteoarthrosis is a very common disorder, especially in elderly population. And this problem is a degenerative process of the joints rather than an etiology-based disease. Osteoarthrosis can be seen in all synovial joints of the body, but spinal column, knee, hip joint, and small joints of hands are commonly affected. However, it's not uncommon for arthritic changes to be seen radiologically, but not always clinically significant. Also, this observation is particularly valid for spinal degeneration. We saw in the presentation of Dr. Zilali. Changes to be seen radiologically. Spondyloarthrosis, degenerative spondylolisthesis, or degenerative disc images on direct X-ray or spatial MRI cannot always be accepted as clinically important. In another word, these types of patients sometimes can be asymptomatic. In daily practice, you can see these types of patients very frequently. You can see significant degenerative changes on plain X-rays, CT scans, and MRI, but clinically the patient has no major symptoms as you see, and does not require surgical intervention. Tandem osteoarthrosis is very common in population, but its importance is not sufficiently stressed. This clinical entity is a systematic disorder. Osteoarthritis generally affects cervical and lumbar area simultaneously, and it's not so easy to distinguish which complaints originated from cervical or lumbar segment. Hip and knee arthrosis are commonly seen with degenerative spine disorders. There are some risk factors for tandem arthrosis, such as genetic predispositions, weightlifting or heavy laborers, elite athletes, obesity, or some strict diets, and smoking. This is the first paper which has been stressed systematically the hip spine syndrome. It's published in Spine in 1983. The authors have found 35 cases in their patient series. They have divided their patients into 3 categories. If only one of the spine or hip joint is symptomatic, it is called as simple hip spine syndrome. In these patients, clinical findings and diagnosis were straightforward and belonged to only one area. The patients may have some radiological findings, but if there is not any complaints, it's accepted as insignificant clinically. In complex type, complaints originated from both sides, and this type is confusing the clinical picture. They have reported 4 cases with misdiagnosis. 2 of them were operated on from hip joint, and the other 2 were operated from spine. Clinical pictures were worsening after the operations, and second surgeries were required. And the last type of the patient group is named as secondary type. In this type, the patients have spine symptoms, but clinical pictures are aggravated by the deformity of the hip joint. This paper is very important because it's published in 1983, but still there are a lot of misdiagnoses between hip and spine symptomatology. Here is an example of a patient with he's a 68 years old male patient. He admitted to the hospital with leg pain for 3 years. His pain was increasing by walking and standing. The walking distance was about 50 meters. By the way, you can see significant disc degeneration and spinal canal narrowing on MRI. But physical examination revealed that there is no neurologic sign. Hip joint motions were painful and severely limited. Here is the direct X-ray of pelvis. You can see on the right hip, and you can see on the left hip also. You can see the degenerative deformities at the lateral. Did you see the cursor on X-ray, dear moderator? I think it's not.
Yes, we do. Yes.
Yeah, okay. You can
Yes.
see the degenerative deformities at here. You can see at the lateral part of both joints, and the diagnosis is impingement syndrome of hip joint. For leg pain, the exact question is it's caused by radiculopathy or coxarthrosis. There are some red flags for radiculopathy and hip disorder problems.
Yes.
Okay. Do you hear me?
Yes.
Okay. In L4 radiculopathy, the pain originated from low back and posterior aspect of the gluteal area and extend to the lateral sides. The tight pain is generally radiates from sacral or low back area. The extension power of knee joint may be diminished. The patients may explain from skin sensational problems on the dorsal part of the foot. But in hip problems, the pain is generally located at the anterior part of the groin zone. The pain almost always increases during weight bearing, such as walking or running, and the flexion contracture of the hip joint, generally usual finding. Here is the clinical pictures of radiculopathy and hip pain, radiating characteristics on the schematic drawings. In L4 radiculopathy, the pain originated from low back, as you see here, and goes to posterior aspect of the gluteal area and extends to the lateral and anterior part of the cruris, and generally radiates below of the knee joint. But in L3 radiculopathy, it is similar, but the pain is generally radiating from the low back to the anterior thigh. It's not usual to extend below the knee joint. Hip pain starts at anterior aspects of the groin and extend to the knee joint anteriorly. If a patient describes a pain scenario which is radiating to the foot, it is not possible to cause by hip joint alone. In differential diagnosis, these two clinical scenarios must be kept in mind. One of them is meralgia paresthetica. This is an entrapment of superficial branch of femoral nerve between the fibers of fascia lata. It's generally caused by the clotting habits such as tight clotting. The other entity is the urinary system disorder. Urinary system pain generally starts from the groin and radiates to the anterior and medial part of the thigh and may be misdiagnosed as L3 radiculopathy. It's very similar. Physical examination is the key point for differential diagnosis of coxarthrosis and radiculopathy. In radiculopathy patients, we can detect sensational findings such as hypoesthesia or dysesthesia at the anterior part of thigh. Decreases quadriceps muscle power and patellar reflex loss may be detected. And you can see the Duncan-Ellie test here. The Duncan-Ellie test is generally positive in radiculopathy patients. This test is based on the stretching of the rectus femoris muscle anteriorly with the aim of knee flexion, and it can be positive in L3 radiculopathy. But in coxarthrosis, muscle power and sensational examinations are normal. Flexion contracture of hip joint is a common finding. Patrick's Fabere and here this one and the Fodder tests. These are functional tests of hip joint are generally positive. And Duncan-Ellie test is generally negative in coxarthrosis. Radiological examinations are very important for diagnosis and treatment planning. X-rays are the first step exam for coronal and sagittal alignments of the spine. Collimation or narrowed views of coronal X-rays in elderly patients is not suitable, such as this X-ray. So wider view, spinal column, in wider view, we can see spinal column and hip joints together. CT scan and MRI is the key for treatment decision-making, but the diagnosis is based both the analysis of clinical and radiological examinations. Invasive tests have a very limited value in differential diagnosis. Intraarticular injection for hip joint is not a widely preferred method because the hip is very deep. Hip joint is locates very deep. It's technically demanding, and the intraarticular pirocaine injection carries additional infection risk for future hip operations such as arthroplasty. Foraminal nerve blocks are more preferable methods than the hip injections for radiculopathy diagnosis. It can be used for diagnosis or temporary treatment of radicular pain. EMG is not sensitive, and generally the results can be changed according to the practitioner's experiences. If there is simultaneous coxarthrosis and radiculopathy and both require surgical intervention, the next question is which surgery should be the first one? There is no consensus in the literature on this issue. Some authors suggest hip surgery should be the first. Some papers revealed that back pain may decrease after hip arthroplasty. The ratio of pain impairment has reached to 66% in the literature. They propose that the hip arthroplasty previously spine surgery may decrease the need for spine surgery. The second reason, hip arthroplasty is more aggressive surgery than the spinal decompression. Its postoperative rehabilitation is more important also. So, after meticulous rehabilitation period of hip arthroplasty may decrease the need for spine surgery. And the third reason is about the biomechanical aspect. Fused spine, especially lumbopelvic fusions, lead to increase the axial loads of hip joint. Thus, increased mechanical loads may negatively affect the fibrotic healing of hip joint capsule after arthroplasty. However, some authors are against of this opinion. They suggest that the muscular weakness caused by spinal canal narrowing or nerve root compression negatively affects the hip rehabilitation after hip arthroplasty. Spinal compression is a progressive process, so delays for spine surgery and long rehabilitation period of hip arthroplasty may lead to permanent neurological damage. On the other hand, waiting for hip arthroplasty does not affect the prognosis. Permanent neurologic damage and muscular weakness clearly increases the postoperative hip dislocation ratios. If you look for pelvic biomechanical properties, sacroiliac joint transfers the body weight loads to pelvis in a 14 to 16 degrees, and these loads transfers to the hip joint in same directions. This is a very strict angulation. It's between 14 to 15 degrees from vertical line. If you perform lumbosacral or low lumbar fusion with instrumentation, axial loads of the hip joints tend to become more horizontal than the original form, as you see in this drawing. And if we extend the fusion to the pelvis with lumbopelvic fusion, axial loads to the hip joint become more vertical. This led to asymmetric weight bearing of joint space, and cartilage damage may be aggravated. If a patient has previously mild degenerative hip disorder, it may progress after fusion. You should give information to the patient before spinal fusion operation. In a simple form of hip spine fusion, only the cause of leg pain must be treated. Radiological findings without any clinical compliance may follow up, but surgery should not be the option for only radiological findings, neither for hip nor for spine. As a biomechanical aspect, spine surgery may be the first line option for complex leg pain. It will be less aggressive. However, hip degeneration may be progress after spinal fusion if exists. Here is an example case. 72 years old female patient admitted to the hospital with low back and leg pain. She had neurological education and could walk only around 100 meters. Physical exam showed no contracture or motion limitation on hip joint. She had severe lumbar canal stenosis. She diagnosed as lumbar stenosis. She was operated and posterior decompression, L3 for interbody fusion with cage, and L2 to L5 posterior instrumentation fusion were performed. Here is the 2 years after index surgery. She had moderate right hip joint pain without motion limitation, but there is a hip joint narrowing, but the joint space is quite similar between right and left one. 5 years later, she had significant hip pain and mild flexion contracture. You can see a narrowing of the right hip joint. The left one is almost normal, but the right one is narrowed. Because she walking distance was become shorter clinically, but she refused the hip surgery at that time, at that year, because her walking ability was satisfying for her. But at 6 years, 1 year later, her walking distance and hip joint motions were quite limited. You can see the joint space is almost gone, and hip arthroplasty was performed for her. She was happy after 2 surgeries and still continues to her life. Another example, 70-year-old female patient. She had severe low back pain and radicular symptoms regarding the L4 nerve root. Radiological exams showed severe degenerative disease and L4-5 spondylolisthesis. Posterior decompression and fusion have been performed to the lumbosacral area. She had hip dysplasia previously, but she had managed with her life without any complaint from hip joint for almost 70 years. 3 years after surgery, her right hip problem aggravated. You see here, there is no joint space and the chondral layer totally lost during between these 3 years. And this problem solved with total hip arthroplasty. As a clinical aspect, if the hip symptoms are more prominent, arthroplasty may be the first surgery. Spinal fusion affects pelvic inclination due to changes in sagittal plane, so this inclination can rotate the acetabulum and lead to prosthesis dislocation. What are the messages to take home? Hip degeneration is generally accompanied in different forms of degenerative spine disorders. Physical examination is very important for differential diagnosis. Every spine surgeon must know how to do hip examinations, such as Fabry tests, Fader tests, because radiologic findings sometimes may not be compatible with clinical complaints, which may lead to wrong surgeries. Physical and radiological findings should be analyzed for treatment method. The worst one should be treated first, but if the signs and symptoms are similar, spine surgery may be the first option. Thank you for your attention.
Thank you very much, Dr. Omer Akali, for your clear presentation. Is there any question? from the participant or comment? If no question, we can move to the fourth speaker.
May I say
Yes.
something?
Yes, yes.
This is Dr. Said Naderi from Turkey, Istanbul. I know
Hello.
Ömer
No,
very
you
well.
can continue to moderate the session. Welcome.
But nereye gitti bu? Okay. Actually, hip problems is one of causes of hip pain. Not only coxarthrosis, but also AVNs also. I mean, avascular necrosis of the femur head also is one of causes of pain. Therefore, these cases should be examined from the point of view of the pelvis problem. Maybe we can discuss in detail later about the other problems. I mean, sacral problems, sacroiliac problems,
Yes.
insufficiency fractures, deep gluteal syndromes, I mean piriformis syndrome, and etc. But I agree with Dr. Ömer Akçalı. All spine surgeons should examine hip and also shoulder. As like maybe not as the detail as an orthopedic surgeon, but in order to exclude hip problem, you need to examine hip, and also in order to exclude shoulder problem in case of cervical disc disease, you need to examine shoulder carefully.
Thank you. Thank you.
Thank you. Dear Dharma, I want to say a little bit word. The hip problems generally makes an leg pain, but as you see, I stressed the importance of osteoarthrosis, hip osteoarthrosis, because vascular necrosis or other hip problems such as infections and other things makes too much pain for the patient. To distinguish this type of hip pain from the back pain is not so difficult, but especially mild or moderate level of coxarthrosis generally produces pain to the from the backside to the knee, and these types of leg pain generally is not easy to interpret this type of pain. It's caused from back or caused from hip. That's why physical examination is very important. It's the key to detect the hip problem.
This is also important from the medical legal point of view, because patients may complain from pain of hip, and if you operate in the lumbar spine, in these cases, the pain may exist, and this is problem. In cases with equal pain, also you need to explain to the patient before surgery that lumbar surgery can relieve one part of your pain, and after the surgery, if necessary, maybe 2 months later, 1 month or 3 months later, you may need hip surgery. If you explain it, there is no problem. But if you don't explain, the patient may experience problem.
Yeah, absolutely. Thank you.
Okay. Is there any other question about this or any comment?
May I ask a question? Can you hear me?
Yes, we hear you, Mustafa.
Yeah, okay. So it's for, I had a microphone issue, technological. I apologize. I can voice myself. My first question is for Dr. Akçalı. How do you, so it's not actually directly on the topic of hips, but in your presentation, you had lower lumbar and lumbosacral surgical stabilization. I would like you to elaborate on adjacent segment disease, if you could, please. And if I can follow up on that question for Dr. Francesco on the sacroiliac joint and fixation, is mechanical sacroiliac joint instability considered prior to having any medical intervention for sacroiliac joint issues? Thank you.
Thank you, Mustafa. And it's very good to see you here.
Thank you.
The adjacent segment degeneration can be a myth because sometimes, especially for younger patients, when you make a long segment instrumentation, long segment fusion, after 10 years, 20 years, 25, 30 years, follow-ups, sometimes you don't see any adjacent segment degeneration. But in my cases, when I presented, we can accept this coxarthrosis, aggravation of arthrotic changes at hip joint. We can accept them as a adjacent segment degeneration. It's not suitable for lumbar spine upper part of the fusion, but I think it's very valuable for inferior part of the fusion. That's why if you fuse the sacroiliac joint, the hip joint may become worsened. Thank you.
Thank you.
I think we can move to the next speaker, Dr. Mustafa.
Okay. If you can allow me, I will share my screen.
Can share your screen, please?
Yep. Okay. Are you able to see the screen?
Yes, yes.
Yes. Okay.
Yes, okay.
Okay. Thank you. I think I got the difficult end of it. It's because my topic was challenges in diagnosing back and leg pain from chiropractic perspective. So it's a huge perspective in terms of properly diagnosing or misdiagnosing conditions. So it is a bit descriptive. So please excuse me on that. It is a problem.
Can you make it a whole page?
Yeah.
Whole screen? Yeah.
Okay. Yeah.
Mm-hmm.
Okay. So it is a problem with multiple faces, which I think it deserves a multidisciplinary approach. And so my presentation will be, again, it's descriptive and it's progressive towards trying to identify a proper solution to the diagnostic problems that we actually see in diagnosing back pain and associated leg pain. So under each subject topic, we can essentially, from the top of our heads, we can count tens of conditions and essentially add up to 50, 60, even 70 different conditions that can cause back pain and associated lower back pain. So from this, I would like to concentrate on mechanical conditions. And out of the mechanical conditions, I would like to first just go over lumbar facetogenic pain. So we have studies that show lumbar facet-mediated pain is a common cause of chronic lower back pain. The orthopedic evaluation of the lumbar facet pain is largely based on exclusion or exclusion of other conditions or other conditions that may be causing lower back pain. So I wanted to see what the risk factors were for lumbar facetogenic pain. So they're degenerative disc disease, having high BMI, degenerative joint disease, inflammatory arthritis, and repetitive microtrauma, and that was touched upon. It could be in a in just patient's lifestyle, or it could be athletics, just accumulated microtrauma. When I looked at the referral patterns for the facetogenic pain, you can easily see that obviously it involves paraspinal musculature. It could easily be mistaken for myospasms or myogenic pain patterns. But then you also see its referral pattern into the gluteal region. And anything at or below level of L3, L4 facets, you can essentially have in varying percentages, see the referral going down the leg, staying above the knee, or going down the leg, going below the knee. We can easily mimic any type of radiculopathy or other conditions that I will try to touch upon. And as well as having an inguinal or groin area referral just as well. The other topic I wanted to, most common conditions that both spine specialists actually see is discogenic. So according to Shayuta and Hancock, up to 40% of patients experiencing back pain may suffer from discogenic pain. So I wanted to see the risk factors, again, for discogenic pain. They're very similar to facetogenic. So again, overweight, smoking, and we'll see how smoking actually affects the general, not as a risk factor, but also as a causative factor. Type 2 diabetes, physical demanding lifestyles, or sitting or extended periods, again, accumulating microtraumas. And men are actually more inclined than women and having underlying connective tissue disorders. So, well, I wanted to see how prevalent the discogenic pain is. According to Constantino and Lingawi et al., well, they say it's only less than 1% of the patients with suspected LDH that have actually serious pathology. So I wanted to, according to public health issues and various publications that's been coming about since the bone and joint decade, since the year 2000, obviously chronic low back pain is a recurrent condition. It's not just one episode. So I wanted to see what the risk factors were in recurrent lumbar disc herniation. Well, if a person is having a spinal disc surgery younger than 4 years of age, they are more inclined to have the reoperation in their 4th and 5th decades of their life. Again, gender, men are more prevalent. Again, having high BMI, smoking, diabetes, activities of daily living, whether it be occupational or sedentary lifestyle, and or just having an unconditioned body, or a body that has lost its conditioning. When I look at the referral patterns for the discogenic pain, it almost perfectly overlaps with facet issues. So again, you have axial pain patterns. It could be in the lumbosacral area, just lateralizing off to the paraspinals. You could have referral going down the leg, staying above the knee or below the knee, or both. Research shows that specific single dermatomal level is actually very uncommon. However, if we do have a specific dermatomal presentation, that it is highly specific of lumbar disc herniation. So having that unspecificity in terms of referral from a lumbar disc herniation and facet, it can easily be mistaken for, I just handpicked 4 conditions. So the first one we actually looked at was your lumbar facet referral patterns, but it can easily be mistaken for sacroiliac, having similar groin referral, having similar somewhat of axial presentation, referral to the gluteal, upper leg, and even to some degree to the lower leg below the knee. And the funny thing is, when I looked into myofascial pain patterns, something that is more simplistic in nature, but maybe more difficult to pick up on, is trigger points. Just out of this confusing chart that I have, I just want to look at, on your reading left, the second picture on the bottom, gluteus minimus, having a trigger point on the gluteal minimus muscle can perfectly mimic a referral going down as if it's a L5-S1 radiculopathy issue. So this is one of the problems, I think, that we see in diagnosing low back issues, just because there's just so much overlap, and obviously piriformis and a whole bunch of other conditions are left out of this presentation. I wanted to see what the correlation was with using MRIs, CAT scans, and X-rays. And obviously, imaging is medically justifiable for those that worsen during conservative care, who fail to respond to conservative care, or having red flags and signs and symptoms initially, even just way before during their case history and presentation. So I came across some interesting studies dating back to 2013, and it will progress up to 2022. A study that was done in University of California showing that MRI use or utilization was medically inappropriate over 50%. Another study in 2020 where clinical guidelines recommend that non-specific low back pain with or without radiating symptoms, not complicated by red flag conditions, should be treated with conservative therapy, and that MRI is not indicated in the first 6 weeks of onset. However, studies have found that 26 to 44% of MRI use is not guideline concordant. Moving on forward, slightly getting into the psychosocial approach of patient care, there's a study that came out and published in Neurospine Journal in 2021, when the reports of the MRIs were actually shared with the patient. Patient had catastrophizing reflections on it. However, instead of reporting on the images, if the clinical findings were reported to the patient, saying that, well, you have a joint here that is restricted, or you have a disc problem, or it's pinching on a nerve, or you have a muscle problem, just keeping it in the lay language for the patient, all of a sudden the outcome measures drastically improved. I wanted to see, because within chiropractic, X-rays are historically been utilized significantly. So I wanted to see what was going on over there. And it's a fairly new publication, 2022. It's a scoping review that shows that X-rays are significantly overutilized within chiropractic, as well as MRIs within the greater medical profession. And so moving on from MRIs, just going into this, I just like to concentrate on the age group of 20 to 50. I would say that's where we see a lot of our patients. And I just like to concentrate on the very first one on top, this disc degeneration. This study shows that 37% of 20-year-olders are actually asymptomatic, though MRI findings show disc degeneration. And each decade, the asymptomatic percentage significantly increases. And by the time we get up to age 50, so if we overlook case history, if we overlook physical assessment, if we just take an MRI, and we're apt to see 80% degeneration, yet they are asymptomatic. So to really concentrate and focus on finding the pain-producing structures within low back has become incredibly difficult, yet we have so many different conditions that perfectly overlap with each other. Moving on into not just the biomedical approach, but also looking at biopsychosocial. From a conservative perspective, we see a lot of patient fear and avoidance versus maybe a lot less it would be within the secondary or tertiary healthcare settings as surgeons, as you essentially save lives in the surgery rooms. But we actually, in the primary setting, we hear a lot of the depression and the fear of avoidance and the anxieties and all that bit that a patient brings into the clinic. So the British Medical Journal defines evidence-based as it's the application of best available research to clinical care, which requires integration of evidence. So we have our evidence, the clinical expertise. Well, the clinician has the expertise, but how much do the primary, the secondary, or the tertiary healthcare providers actually calculate in the patient values, which essentially are going to make up the psychosocial and the environmental factors into their pain perception and their reflection on what they think they're feeling. So this, yeah, moving on from there, I wanted to see what the evidence was on psychogenic conditions and psychosocial factors in patients' perception of pain. So psychosocial factors are important in musculoskeletal pain management because they can affect pain intensity and disability. Negative thoughts can negatively influence the perception of pain, according to a study back in 2009. Moving on forward, in 2018, more recent publication, it's a systemic review. 83% of the articles reported within this review showed association between psychosocial factors and acute pain becoming chronic. 29% demonstrated that depression was a possible predictor, and 35% of the studies found fear of avoidance to be associated with chronicity of the pain. Interestingly, there's a meta-analysis of cross-sectional study that 30% of smokers will likely to suffer more low back pain and will likely to become more addicted to use of opioids than non-smokers. So this slide and then the predecessor, it actually just overcomplicates having multiple conditions perfectly almost overlapping on one area of the body, with utilization of diagnostics and risk factors essentially becoming almost as a causative effect of having back pain. So this is, I think, to me, is one of the most detrimental factor that will go into making the diagnosis of low back pain problematic. Us chiropractors are to be, from my perspective, are to be blamed significantly, because to us, everything is a restricted joint. So we just want to manipulate it, we want to move it, and then be done with it. However, when we actually look at this systemic review, and it's fairly new, overall in the greater medical profession, associations between cognitive biases, they reach up to 36.5% to 77%. If we just go by this percentage, it's very likely that all of us in this room will actually misdiagnose with our initial entry to the patient and then potentially correct our diagnosis. To fix this problem in this complex world and with increased complexity of a patient, these are the solutions that, as a chiropractor and from a chiropractic professional perspective, I offer: having inter and intra-professional collaboration, better communication between professionals, multiple conditions with very similar clinical presentation, though back pain seems to be very more simple than diagnosing a cancer and things in those lines as sinister is concerned. But I think we may be taking it to a point where we're undermining its complexity, and having unjustifiable or medically unjustifiable use of advanced diagnostics. And at least in conservative patient care, and before I actually took the platform, I could not catch that Dr. Saeed. He actually touched upon it from a medical legal perspective. Being able to justify everything that we do and not considering the patient's values and wants and needs in terms of what they feel like they need for their body. And obviously the very last bit, which is my big one, is not having clinical biases. That's my presentation. Thank you for listening. And I will unshare my...
Thank you very much, Dr. Mustafa, for your presentation. Is there any question?
Here we go.
For Dr. Mustafa? Or comment?
Great talk indeed. I must thank Mustafa for his great talk. Actually, we don't look at those items like behavioral problems, the psychological and biological and social problems of the patients we ignore sometimes because we look everything as if we will operate, we will make
Yes.
surgeries. So this webinar has focused on this, and then I thank all the speakers for that.
Özlem ışığı yak.
Dr. Naderi.
Yes, it's very good talk, and we learned something from chiropractic expert point of view. The main difference is a chiropractic, they can get cervical spine, lumbar, thoracic spine, MRI, and then decide to do chiropractic in any part of the body. But most of neurosurgeons in these cases get only lumbar spine MRI. This is so because, as Dr. Zileli said, when we find something and if it is symptomatic, we operate it. But you do not operate, you apply chiropractic techniques. The main problem in these cases is overlapping. This is very important. But I think in most cases, I get lumbar spine and sacroiliac MRI, both in these cases. And these MRIs can reveal any other pathologies in the sacrum, sacroiliac joint, and in the pelvis as well. If needed, we can add pelvic MRI to see coxarthrosis and the upper part of the femur. To me, the differential diagnosis is very important, and what I have seen so far is lumbar oriented pain are not, there is no tenderness actually. But in all other sacroiliac and piriformis or coxarthrosis or other problems related to the hip, there is local tendernesses. This is very important. Therefore, actually, I recommend to my colleagues to examine patients not only in the supine position, but also in the prone position, and because you can reveal facet joint pain also, a local tenderness in facet joint pain in other problems, and this may help diagnosis, but overlapping still is a problem in these cases. We cannot hear. Any other question?
Do you wish to comment something, Ömer?
May I ask a question for Mustafa? I wonder your decision-making options for sacroiliac joint. How you evaluate the patient, and how are you making a decision-making? How you plan the treatment for sacroiliac joint as a chiropractitioner?
Yeah. So
because in Izmir, I saw too much patient. We follow together, and I know there is a huge impairments of from the pain from your treatment. What's your opinion?
Yeah.
How you decide? How you make a decision for treatment?
Yes. So obviously, the patient presentation and listening to the patient's subjective complaints, and more than listening, but trying to make sense, is very important. So taking a thorough case history is very vital. After having taken the case history, obviously we'll follow through with a focused assessment, focused examination on the differentials that we actually come up with, whether it be facet or sacroiliac or disc or piriformis or gluteal tendinopathy or, what have you. And as we go through our tests, we will rely on the specificity and the reliability of the orthopedic tests that we're using to see if we have positive positives or false positives, so we can correlate them with the subjective findings of the patient. Putting 2 and 2 together, it essentially, literally, you can make almost a determinate diagnosis, like 80%. And if you don't have any red flags, then traditionally, and also legally in some parts of the world and jurisdiction-wise, we can't really refer for MRIs, or in some parts of the world, you can. So you can make use of the diagnostics to confirm your findings or exclude your differentials. And the treatment end of it is, so in Izmir, my relationship with you, Ömer, actually, and Mehmet Zileli has always been very respectful, so I appreciate that. And so as a chiropractor, when I fell short within my knowledge and practical skills, I had you for me to refer my patient to. So that was a perfect multidisciplinary approach. And sometimes the patient actually went through surgery, and sometimes the patient came back to me and the patient is saying, well, the surgeon said, just go back to Mustafa, he'll take care of it. And so it was actually a perfect, setting to practice that multidisciplinary practice. And the actual application, in a lot of the times, we do use different approaches of manipulative techniques. Sometimes they're just manual, hands-on. Sometimes they're table-assisted. Sometimes they're instrument-assisted manipulative techniques, depending on the varying degree of the pain the patient comes in with. I had one patient when I was in Izmir who I could not even, I barely put my hands on to do any application. And so I had a really close friend who's an anesthesiologist. She came in and she delivered a intra-articular injection that calmed the patient down, calmed the area down, and then we were able to proceed with manipulation on the local anesthesia, and then the follow-up for if I'm not mistaken, 6 months or so, she was asymptomatic from that there on. So that's essentially how I did it and how we teach our future chiropractors to do, and hopefully they do it. So that's basically it.
Okay, thank you.
Thank you.
Okay.
Mehdi, there is one question in the text. Some cervical spondylotic patients complain back pain. What is the reason of that? Is it funicular or tract pain? Do you have an experience? The question is this.
Was that to me?
I don't know. Anybody?
Well, actually, the rate of tandem spinal stenosis is 20%. I mean, in 20% of cases with lumbar spinal stenosis, there is also cervical spondylotic cervical spine stenosis as well.
Mm-hmm.
And also, this is same for cases with cervical spinal stenosis. In these cases also, there may be lumbar spinal stenosis in 20%. Therefore, actually, we operated in these cases from cervical and the lumbar spine in some cases. If cervical spine is much more severe, we need to operate first cervical spine. In some cases, there may be also thoracic spine stenosis as well. This is so because degeneration doesn't select only one part of the spine. Degeneration is a problem of the aging, it start in the knee, in the hip, and then lumbar spine and cervical spine. All the body can experience this problem.
Yeah, I think probably we can conclude this panel as there is no good correlation of the films, MR images, and symptoms of the patient. And there is currently an overuse of the films, and there is a neglectance of good examinations. Can we tell this? Mustafa, what do you think?
Yeah. I mean, of course, I'm not going to oppose you. It's
Ömer?
I would also add in the clinical cognitive bias as one of my favorite ones. We're one to blame for it as well as chiropractors.
Yes. We can conclude this session relatively. The low back pain and radicular pain are frequent symptoms, but not all originate from spine. There is many different diagnoses, differential diagnoses. The percentage of from spine is less than 1%, and most of pain are non-specific, low back pain and non-specific. We should do the correct diagnosis. We should examine the patient, do the tests, do the radiological investigation, and the essential to do the correct diagnosis of the pain to give the adequate treatment, I think.
Okay. I also thank all the speakers and all both moderators
Yes.
for their valuable contributions.
Thank you very much. Thank you very much for your
night.
participation. All. Thank.
Bye-bye.
Thank you. Bye.
Bye.
Goodbye.
Goodbye.
Goodbye.